Lorraine Sherr, who's a professor of clinical and health psychology at the University College London, is unable to be here in person, but we are going to bring her in, I believe, through our WebEx process and have her join our conference virtually. Magic at the back is going to happen.
I'm going to talk because I'm here and I can feel your presence. So if you can hear me, please say hello.
We can hear you. Oh, we can even see you. How fabulous. Hello, welcome.
So hello, everybody. I'm going to talk about women and HIV and look at the mental health considerations. Next slide, please. So we do know that those people with mental health problems are more likely to get HIV in the first place. And we also know that people who have HIV have a greater likelihood to develop mental health problems than the general population. And we need to look at mental health sequelae of HIV itself, things like cognitive implications, as well as any kind of virus or comorbidity, as was just really set out interestingly in the last talk, but also the mental health sequelae of treatment, things like the burden of lifelong treatment, the burden of adherence, and the side effects of treatment. Next. Next slide. There's a lot of gender difference in the impacts of HIV. You've seen some of the literature so far from people. I'm going to focus on the mental health. Women report more shame or guilt. Very often, studies show lower quality of life scores. Many studies showing sexual activity is adversely affected by HIV. Health-seeking behavior, medication adherence, clinical outcomes. Decreased sexual desire has been monitored, poor sexual functioning, and sexual inactivity. Lots of work looking at coping strategies and ability to disclose HIV status and the differences by gender. Multiple burdens have been reported. A nice study on violence also set out the particular gender and women-associated experiences of violence associated with HIV. Next. Also, when we're looking at women, we shouldn't just think we're taking this one broad group. There's a very interesting emerging literature on trans women, and we should be cognizant of it. And they report very specific mental health issues. Really interesting studies by Langbeek and Brankenu, and one about to come out by Lancome Duncan, a group in Canada. Excellent work on depression rates and treatment engagement. Very important for this particular group. Next. What about mental health, HIV, and women? The literature, and Sharon referred to this earlier, is very skewed towards reproduction, and we all know that there's more to women than childbearing and mothering. I'd like to take a life course view. I'd like to talk a little bit in my talk about children, youth, adults, and aging. So it's going to be a bit of a marathon, but we'll go quite quickly. I just ran a PubMed search when I put in the word HIV and AIDS, and we have a couple of 100,000 papers. When you look at mental health, you see even more studies. When you look at women, there is a robust literature. But what happens when you put all three of them together? You get a really scant and small amount of studies, which gives you an insight to the understudy and how little we know. Next. I tried to look at the 4 key bottlenecks. The first one is that child data in all of the UN and statistics don't disaggregate by gender. Up until 15, they just call them children. So we have this invisibility of the girl child. Adolescent data, I have gripes with UNAIDS on because they merge 15 to 24. Now, UNICEF tells us an adolescent is up to 19. And by clumping adolescents with early adulthood, we have a blurred adolescent girl child. Data is often not disaggregated by gender. So we have this sort of buried female findings, but it was good to see Sharon's talk earlier that shows this might be changing slightly, and this disproportionate study at the childbearing women, which hides our youth, our aging, and our middle-aged women. Next. we always go through all the problems and have the last slide as the interventions. So I wanted to put my first slide, really, as the interventions, because this slide will summarize to you that there actually is quite a lot of intervention. There's mental health interventions that are shown to be efficacious, and they do manage quite a lot of mental health symptoms, like the CBT systematic review by Pew very recently, and they do have outcomes that are interesting. The Barrett study is quite interesting because there is a movement about using non-specialists to intervene, and although there is a big debate about that, maybe that is one way of looking at the great lack of skills in this area, especially in low-resource settings. Next. Positive mental health has also been looked at. We shouldn't always focus on depression, anxiety, and negative stuff, but what about positive and potential growth and resilience? Next. And also neurocognitive, a very recent review by Rubin showed that when you look at the differences according to sex, it's really quite problematic. Very few studies have sufficient power to look at this, so this just lists similar to the biomedical studies in the mental health field is exactly the same, and those with adequate power do show some greater levels of burden in women, something around memory, information processing speed, and motor functioning seems to be emerging. Next. Talking a little bit about the London Women's Study, there's two of those, the PRIME study and the one we conducted. Briefly to give you an insight to this, basically we found the majority of our participants were well educated and getting treatment, but slipping when it came to actually getting perfect and high quality sustained treatment. Next. When you look at mood, I think our findings are really interesting. So look at this high level, over 90% on many of the negative moods. And when you look at cutoff points, over a third falling above cutoff on validated measures of anxiety and close on a half on validated measures of depression. And suicidal thoughts are really worrying. If you ask the general population about suicidal ideation in the last week, the rate is usually something like 3%. And when you ask HIV-positive women, last week's suicidal ideation rate is over half, which is really worrying. And then we also looked at sexual dysfunction, and we found a mean score of 20, which puts the mean score within the mild dysfunction category. So there's a lot of areas where women do need to have some of their functioning supported and understood. Next. Mental health burden was significantly associated with, could you move on the slide? Physical, psychological symptoms, symptoms of distress, and if you can move it forward quite quickly so we can cover it. Sexual dysfunction, keep going, and adherence, keep going. And older women, when we looked at our older women, and in fact we defined older women as over 45, and many of us with grey hair in the room will say that 45 is really not that old, but we do find higher anxiety and depression in the older within the group. Next slide. And the PRIME study was an interesting follow-on, thanks to Shima Tariq and all the team on the study for allowing us to use our data. This is 21 clinics with just under 1,000 women, and not to go through the whole study, but just to tell you where you looked at those who had none or very mild distress scores on validated scales and compared those with moderate or severe distress, what you find is that predictable viral load, missing appointments, and of course suboptimal adherence is significantly associated with higher levels of mental health distress. Next. I'll draw your attention to the middle one here is to look at women across the age span, premenopausal, perimenopausal, and postmenopausal, and you see that all the symptoms are significantly different. The perimenopausal woman suffering quite a lot, and if you look at the psychological symptoms, not only are they worse off, but look at how high they are for all three groups, and this is very often there's no resources to help support them. Next. my point before was that women shouldn't be clumped together as just all women. When you disaggregate for our study in ethnicity, you can see great variation. Next. And this just confirms that. Next. Now, this is quite interesting because very often mental health is measured conceptually, and this study by Helen McBaster and the team looked at mental health over time, and they generated two groups of women who had baseline and at 1.5 years follow-up. Those who had no suicidal ideation, the group who had at both times, we call the chronic group, improvers, those who had at the beginning, but by the follow-up they were okay, and the deteriorators, those who had no suicidal ideation at the beginning, and by follow-up they had. And what's the effect of being in one of these four groups on child development? Next. Well, what you see is significant effects, mostly driven by the deteriorators and also specific effects by the chronic group. What's interesting is those who have no problem have the best scores throughout, and those who improve pretty much reach that on all of the variables in terms of the child's development. So it shows you that mental health is a huge burden, but if you intervene and the HIV-positive mother does better, not only does she improve, but her child's development can improve. Next slide. And here you see the same when you look at not suicidal ideation, but a broader measure of common mental health disorders, the same finding. Next. A few little slides, if I've got time, looking at children as their gender is both important and they're little. Next. You could click right through these slides quite quickly. This is just the limited focus that I spoke to about on children. Next. And here you see that, what's a mistake, all the data that we are given is not disaggregated by gender. Next. Next. And this is just shows you the UNICEF data. Next. That if you want to disaggregate by gender, you can, and you'll see very specific differences. Next. And again, next. Just the invisible aspect of children from early in the HIV epidemic has just been confounded by this gender invisibility, and it's right down to childhood. Next. A few more minutes on teenage pregnancies, because these are young women. Women with HIV who have mostly clustered in sub-Saharan Africa, but they are very invisible, and we've just done a review on them, and very little is known about them, but they do have particular problems. Next. Adolescent motherhood is a global problem, and it's the layer of complexity when you add HIV or HIV exposure, even if they're uninfected, but they were HEU. And remember, the HEU children are now reaching adolescence, and they themselves are becoming pregnant. Next. There's a few studies that have shown that they are at greater risk of not staying on treatment. Many discover their status simultaneously with their pregnancy. 0 studies on them are on HIV adolescent mothers and postpartum risk, and 0 studies on their infant development, which we're trying to address. Next. What's the mental health and adolescent pregnancy? Depression is elevated. Depression rates. This is a study which tried to look at predictors and found that HIV was a predictor. So it's an indirect study. Anxiety, trauma, and suicidal behavior has been shown. Mary Jane Rotherham Boris in California has tried to look at a working definition of resilience amongst this group, but found that nobody who was HIV positive over a 5-year period could be categorized as being resilient. So stark worry coming out of that data from California. Next. Just remember that although we have this view that teen pregnancy might be problematic, it's not always bad, it's not a crime, and very often the determinants of negative outcomes are about the social circumstance. So, for example, in Tanzania, if a girl becomes pregnant, she's expelled from school. The father of that baby is not expelled from school, and often it's the lack of education that will predict how the child and the woman fare, rather baby in South Africa, where we're looking at 1,000 adolescent mothers and their babies. We're comparing them with a comparison group, and what we're finding is some very interesting data where if you look at the adolescent girls who are not mothers compared to those who are mothers, if you could forward them and we could just see the graph, next. There we go, next. What you see here is that the mothers have score worse on a number of viremia risks and not having their viral load data available. Next. For today's talk, I took out of this data the 4 groups: never pregnant and HIV negative, the control group; ever pregnant but HIV negative, a comparison group; and never pregnant but HIV positive, and the pink group, which are ever pregnant and positive. And just looking, for example, at the suicidal thoughts, you'll see how elevated it is for those groups. So they get a kind of a double burden. Next. So some quick slides, just if you look at the systematic review to try and say, do they note the gender and do they analyze by gender? You find very, very often they don't. On schooling, there's a female disadvantage. Next. On nutrition, 9 analyzed by gender, mixed findings, no difference in gender really. Next. When we looked at cognitive development, next, we find gender, of all the studies, 17 actually gave the data, but only 4 analyzed by gender, so there were very few differences, but I think we're underpowered to know that, which really needs to be looked at very, very quickly, because we do need to know about gender difference in cognitive development. Next. In bereavement studies, next. Of the 15 studies we found, 4 report on gender of the parent and child, 1 no gender data, 12 described gender of the child only, 7 analyzed, and there's no significant difference pointing to any gender differences. But only when we look at it can we actually say that with certainty. Next. This is just showing the gender differences in suicidal behavior. Please be aware of them. Next. And this is just to point that some of the intervention studies, gender is really quite an important factor. And when you disaggregate, you do find differences, for example, in risk behavior. Next. And in boosters, when you add interventions together, there is a gender effect on enhancing how efficacious they can be in changing risk behavior. Next. So finally, I come to an end just with conducting a study to look at this accelerator hub, and as with all studies mentioned earlier on, one has to have a very specific gender portfolio in these large studies so that we can tease out the effects for young women as well as for men. Next. Okay, a quick run through of the mental health, and thank you for tolerating the difficulties of remote presentation, and thank you.